So if we go to the questions, and we've had quite a few, so I'll be picking them out. The first one was looking at the microteams, actually, the microteams question. And I do wonder whether any of our panels could put their hand up if they have tried the microteams, and what their feelings were about it. So Susie will go there in a second, and also to mention that Valentine Healthcare has looked at microteams. They've looked at paired or 3 GPs with 2 nurses, and they've shown an increase in continuity of care with interventions, but there may also have been an increase occurring before the project started. So that's really fascinating. So Susie, tell us what you think about microteams.
We did try microteams, but we ended up, it might be to do with just the way the GPs work, with the number of sessions they work. It ended up basically being 2 teams, and essentially that just wasn't continuity, because all of the staff, with the days that they were working, fell into one team or the other. But I think that might be something that affects smaller practices more. But we realised very quickly that that actually was not continuity. That was basically how it was before. I think we probably want to revisit it now that we've got more ANPs in. We didn't have very many at the time before. So you do have to think very carefully about what your team looks like and how you're going to operate. If you're predominantly still largely GP orientated and limited sessions, what you feel like at the time is that it's not continuity.
Okay, any other comments from the panel? Oh yeah, Julia?
One of the things, I haven't got the answers, by the way, I'm just going to post some more questions to this one. The GP contract now asks for an accountable GP for every patient, so you've got that consideration to take. And then it gets a bit more messy because you've got all of these other clinicians and supporting roles coming into the practices as well, who will be a sort of MDT around the patient. So that's another sort of aspect that we haven't explored, but it's another complication that we have.
Okay, and I think it was Liliana Risti who mentioned this question, and she was pointing about big practices. I think one of the messages from Valentine Healthcare was that you work in smaller units. I think she named each unit after I think it was a local ship, something like that. And that smaller units seem to work more effectively. But I think the jury's out here, and there's a lot of discussion to come on that. So the next question, which sort of leads on to that a bit, was about handovers. And this was an interesting question because they were saying, how do you minimize handovers? And I wasn't thinking of handovers at all when I looked at continuity in our practice. So I wonder what the panel thinks about handovers. I saw Kevin shaking there, but put a hand up if you've got a question. Yeah. A point rather, if you want to make a point. Was that Kevin? Do you want to dive in?
Yeah, I don't really understand that question about handovers. I mean, I think continuity is all about relationship building, isn't it? And so that's why I struggle a bit with the micro team idea as well. And so we should think beyond just GPs. So in our practice, we're trying to use practice nurses to become skilled in lots of different conditions so that they can manage the same patient with all their comorbidities. And I think what we're also doing in practice is trying to encourage them to have clinical meetings. So in terms of handover, perhaps discussing complex patients in clinical meetings allows the rest of the practice team to understand what's going on with patients, and the importance of good clinical record keeping. It's not a substitute for continuity, but it does make it easier for other people to pick up when you're not there.
Yeah, I'm right. I think you're right there. When we're talking about relational continuity, I'll come to you in a second, Julia. And the interesting thing is there's organizational continuity in the background again. So I've heard it talked about as front stage, patient and doctor, or healthcare worker and doctor, and backstage with the IT. And certainly in my practice, it seems to be that the messaging is increasing, but not actually a physical handover that's happening. And in theory, handover should be less if you've got the continuity. Julia, you had a comment there.
I did. I just wanted to add that the Valentine Project had designed a template to support handovers, so it may be worth having a look at that template and adapting that for needs.
Okay. If there's no other comments about handover, I'll just go on to the next one, which talked about and tracking waste, which was interesting as well. So waste in terms of testing or other things that you might be done. And I don't know whether you've got any comments about that. Again, hands up if you have. I saw Kevin twitch his finger again. Then go ahead. Yeah.
So yes, I mean, this failure demand, I think, is a concept people perhaps haven't recognised before. But when they've looked at it in other areas, something like 30 to 40% of demand is failure demand. So it's a substantial amount of our work. And Susie rather mentioned with investigations, that's a classic example of the amount of failure. I mean, in our practice, we're still seeing blood results look twice at, somebody's looking at it on the day and then handing it over to the other doctor. So we're looking at that. But there's a huge amount of failure demand. One of our managers is trying to look at ways of trying to measure that, but it's massive. So if we could actually reduce it, we could considerably reduce our workload by certainly 20%, I think is possible.
Yeah, and I think that message is coming out, is that continuity of care is almost about addressing workload and taking control of things a bit more. And certainly what frustrates me as a GP is when I see people having extensive tests done and repeated, or admissions or referrals, when I think, well, why that wouldn't have happened, I don't think, if there was a continuity and people knew about what happened before. But yeah, so the feeling then is probably it reduced waste, or we think it does. Any other comments from anyone about that? Okay, Julie.
Thank you, Mark. And I think just in addition to what Kevin has said, and we've just had a question in the chat from John McGuinness about whether there's any evidence to reduce GP workload. That's certainly something we're focusing on in the remaining months of this year, looking at actually how do we correlate the results of increasing continuity, and how does that actually draw down to the detail of how did this change for the GP. What were the number of blood test results they were doing? What was this? What was that? And it is just an exploratory thing that we're going to be embarking on. And if we can actually find some really good evidence that can demonstrate here's the improvements in continuity and here's the actual reduction in workload for GPs and your clinicians, then we'll share that with you. But certainly this is still a journey that we're on.
Okay. Oh yes, Jake.
So I think it's really interesting, the idea of reduction in workload. I sort of think of ourselves as we've got a fixed bucket of resource that we try and use to do the best for our patients. And what we might find is, rather than sort of reducing workload, what we're doing is higher value work. And so instead of sort of repeating sort of lower value types of activities, we start doing more high value work that gives better patient outcomes. And I think the challenge about measuring it is the length of time to monitor that change. I don't ever envisage that continuity is going to leave me with empty clinics or no blood test results or no documents to look at. But what I hope is that over time, that the care that our patients receive and how they experience their lives improves.
Oh yeah, Kevin.
Well, another thing that I'm thinking about waste really is, if you look at what happens in a consultation, probably only about 5% is entered into the clinical record. So 95% of what happens in that consultation remains in the doctor's head and heart. And unless they continue to see that patient, it's wasted. So we're throwing away probably 95% of every consultation unless we have continuity.
Yes, and it's really hard to quantify that information that's held in that doctor's or healthcare worker's head. Yeah, and I mentioned healthcare worker because, as Kevin said, within our practice, we're finding that continuity is often with a lead nurse. Our diabetes nurse, for example, knows our patients very well and perhaps better than the GP. Their next question comes on about how you influence other practices in your area and spread out the behaviour of continuity of care, or encourage collaboration with practices in the area. And interestingly, this question also brought up the importance or the relevance of involving patients and encouraging patients to participate and promote continuity. So I don't know whether anyone could comment on that one. So we've got Julia and then Susie.
So from the One Care point of view, we started off with 9 practices in the first wave, and we took what we learned from them we took out to the second wave and then collated that and took it out to the third wave. So each time it's about sharing the ideas. The other thing that's quite powerful is to be able to share the data, to be able to see your data benchmarked with somebody else's, because you might get 17% or 60%, but if you have no idea how that sits with everybody else, you have no idea how you're doing. So those were two really important aspects for us in terms of rolling forward with other practices.
Okay, and then I think it was Susie.
And I think for me it was about, we know that there's evidence about continuity improving care for patients. My conversation with the clinicians here was much more about answering some of their frustrations. So actually the rolling out this project was quite easy, given that there was such high dissatisfaction with the amount of actually sort of, we could call it wasted appointments or failure demand, where just because a GP looked at the results, the patient ended up being booked in with them when they've never met them before. And that was something that really unified all of the clinicians. So I think we all want to do lots of great things in terms of improving care to patients, but we're all feeling somewhat overwhelmed a lot of the time, and it's hard to see to prioritize it in the normal day-to-day work. But actually focusing on what are the problems that people face in the practice is quite a good way to engage people, because any prospect of clinicians having less frustration in their day was really welcomed by them, and there were no there was no hesitation at all. So you can focus on the difficulties that people experience, because you know that there is evidence for continuity of care, so that the patients are going to get something improved.
Yeah, so the message there is something about, well, as we've said already, is tailoring it to the practice, working where you're at, what are the issues, and then addressing those issues with the continuity, if you can, by working where you are in the toolkit. Jake, you were going to say?
So I'd just like to come back to Kevin's comments earlier, really, about it's about changing the mindset. And I think once you've made the decision and committed to wanting to do something about improving continuity, it's then about talking to people. And I think the biggest impact that we've had going around the practice is through conversation and talking to people and understanding what they're doing, what they've tried, what's worked, what's difficult. And if you're doing something well, you should go out and talk to people about that and be an ambassador about it, what you're doing. And if you're struggling, you should ask questions and go and talk to people who you think might be doing it well. So yes, conversation is really powerful.
Yeah, that's good. Okay, now, as we've said already, if people need to leave, that's fine. We're going to be recording the questions and answers, but I'm going to carry on for a little longer. And one of the questions that came up was about subgroups. Are there certain conditions that might benefit more from continuity of care, certain groups there? And I think Julie would have touched on that a bit, but anyone want to add on to that from their experience?
So in One Care, our steering group looked at what they thought were cohorts that could benefit. So they were the frequent attenders. There was quite a few practices looked at patients who come to the practice a lot, who consult a lot. We looked at severely frail patients with high Rockwood scores, the palliative care, the care homes. And I appreciate things have moved on since we started doing this, so there's other measures covering those. But yeah, I think sometimes it's about picking a particular cohort of patients and working with that cohort of patients, regardless of perhaps the condition, and getting it right for them, I think has been the key.
Yeah. Okay, Jake.
So I think historically for conditions such as palliative care, we've always tried to prioritise continuity for that. And every practice I know, I think, tries. I think if you look at the 80-20 rule, 80% of our work is done for 20% of our patients. So it's that the frequent attenders, the people with chronic conditions, those groups are likely to see the short-term wins in providing greater continuity. However, I would say the other 80% who you're not looking at will move into that 20% cohort, and trying to build those relationships early and looking about if you're going to really change population outcomes, you have to get them before they're sick. So seeing them taking on that proactive step of checking the blood pressure and having a conversation about long-term management, these types of conversations happen with my patients who I know, and I'm able to say, your weight is an issue. because I've had that sort of 4, 5, 6 consultations over the last couple of years, and I've watched it, and it fits more easily into the conversation. So, you know, I'm a big believer that actually continuity for all, if you can.
Great. And then Susie might be the last point.
And I think you just have to remember about operationally, it's actually quite difficult to know who's going to be sort of site streamed for continuity. It's actually easier from a reception and front door perspective for everyone to be getting continuity, because it's actually quite hard to flag people without putting a little message on the front screen of EMIS to say needs to see usual GP. You know, you can't turn the bar from blue to another color, or there's no easy visual way of tagging people. So just have to think a lot of the sort of problems might start at the front door in terms of remembering who does and who doesn't get it. So actually all is sometimes easier.
Yeah, and then that makes the point, of course, that we're trying to influence the clinical system providers to provide all these tools, and I hope they will do. And perhaps in a few years' time, we'll be sitting here going, "How it's so easy now; it's all there." Yeah. Jake, did you want to make a last comment?
Yeah, and I would just say, but sometimes it feels easier to take a cohort of patients who are small and defined and do something with them, and I think that's great. Do it, because you'll have success and it will build and you'll get that ripple effect. And so it really comes back to start what you as a practice are ready for, start with what you're interested in, start with what your population needs you to focus on, and go from there.
Yeah, and that's a really good point to round up on, but because what we'll do is we'll finish the main session now, but if the speakers and panelists can stay on, that'll be great. So yeah, start small and build up. And don't forget, continuity of care is important. It can be achievable, as you've just heard, and it can be done by anybody. Start small and build up. So I'm going to say thank you to all our speakers. Thank you to Candida. Thank you to Julia and to Jake. And thank you to Kevin, Susie, and Julie. Thank you very much indeed. And well done, everybody. Much appreciated. Thank you.